Good evening, Dr. Babu. Good evening to all.
You can start. Hello. Hello. Hello.
Hello, good evening, Nancy.
So you can start.
Yeah, just 2 minutes. I will wait for 2, 3. It's only 8, 2 minutes we'll wait and then start. Nancy, shall we start?
Yes, sir, you can start.
So, good evening to all of you. I think this is the 69th session on the challenging case series. So, I'll start my share screening. Is my screen seen?
Yes, sir, you can see your screen.
So, as usual, we start with the short case first. This is a story of a 22-year-old man. He gave history of progressive difficulty in walking for the last 3 years. He gives history of dragging with both feet. No sensory complaints or bladder problem. History of bilateral defective vision for the last 4 months. I have not got the complete video of the patient, only gait is there, but I will tell the findings. On examination, hymenal functions is normal. Cranial nerves, visual acuity is 6/36 bilaterally. Pupils normal, reacting to light. No field deficits. Fundae were normal. Rest of the cranial examination was normal. The motor system, the tone in the upper limbs were normal. However, spastic in both the lower limbs, slightly more on the right side. Power was the upper limb normal power. The lower limb, proximal muscles were normal. Distal muscles were mildly weak. There was bilateral claw feet deformity. Deep reflexes, upper limbs were brisk in both upper limb. The lower limbs, knee jerks were brisk, ankle jerks were just elicitable. Plantars were outgoing. Sensations normal. This is the gait of the patient.
Speedy.
You're dragging your both feet more on the right side. Be too carefully, it's got some mind wasting of the small muscles of the feet. Difficult to make it out.
More on the left side.
It's also got some like, but there definitely spasticity is there by that. So summarizing the findings, he has got one good to quickly run through the finding. In the cranial nerves, it's good visual acuity is decreased, but pupil fundi feels normal. Motor system, there is spasticity of both lower limb. Power was normal except for the distal muscle weakness and bilateral claw feet. DT are all brisk except the angle check, which is just normal. Lambda subgoing, sensations normal, and the gait you already saw. So, what do you think is the likely site of lesion possible diagnostic possibilities? You want to clarify? You can ask, yeah, please.
She has a spastic paraplegia is there, sir,
Yeah.
with peripheral neuropathy also.
Okay,
And
good.
since he has a vision loss, is there optic nerve is also involved?
Okay. Is it lesion in the? Do you think the vision loss is the optic nerve or somewhere else?
Could be a retinopathy.
Okay, but the fundi were normal.
Okay, sir.
So we have to consider a non-compressive myelopathy with possible. The fundi were normal, so no pallor or.
No, fundi were normal.
Okay, sir.
So the non-compressive myelopathy above L1 myelopathy may be compressive or non-compressive, more likely non-compressive.
Okay. What you could
history is not evident.
Okay. What do you think the possible etiology could be?
Family history is there, sir?
No family history.
Still can be HSP, TTSP, or even a tropical ataxic myelopathy.
Okay, right. So
nutritional.
Yeah. So most likely, what is the point in this patient to suspect a non-compressive myelopathy? You know, compressive myelopathy can also produce present only with spastic gait, without any level. So, for example, a craniovertebral anomaly or a cervical canal stenosis can produce non-compressive myelopathy. Mimic a compressive, a non-compressive myelopathy. The clue is that it's got a visual loss, no?
Yes.
That is one. What is the other clue to suspect a non-compressive myelopathy?
Clawings.
Yeah, claw
No
feet.
blood.
It's got a claw feet deformity. So that means it's a non-compressive myelopathy. So what do you think? Maybe HSP variant, okay. But where's the site of lesion for the visual loss? Is it due to refractive error or something like that? It's fundi were normal, feel normal.
Can still be in the optic nerves. Optic nerve.
Yeah. Okay, optic nerve. Okay.
Be retrogenic. I mean, there are no eye findings at all, sir, other than the visual acuity.
Exactly.
So you would look for a posterior more lesion.
Right. Posterior, where would you like to consider?
Behind the genital.
sir.
Pardon?
Retrochiasmal.
Behind.
Yeah, retrochiasmal. Okay. So you have to take that into consideration for the etiological diagnosis also. He has got a non-compressive myelopathy with a lesion there. How can you explain that myelopathy part also? Okay.
Sir, but the vision is normal. I mean, the vision is impaired. So to have a adrenal leukodystrophy, can you have this aggregate loss and paras? I'm not very sure, but you have to think of one possibility could be adrenal neuropathy.
Yeah, adenomyelin neuropathy. So that if you the lesion is the occipital lobe, we can consider that possibility. Correct? Okay. So what do you want me to do in this patient? MRI, no?
MRI.
Yes, MRI, the cervical spine was done. That is, cervical spine was normal. The thoracic spine, you can find a cord atrophy in the mid dorsal region. Did you see the cord atrophy?
Yes, sir.
Yeah. You can make it more clearly there. So, what else you want to do now?
Brain.
Brain with optic chiasma.
Okay. So this is MRI brain.
Adrenoleukodystrophy, sir.
Yeah, good. As Uma said, it's adrenoleukodystrophy, adenomyeloneuropathy.
Myeloneuropathy, yes, sir.
He's got a myelopathy, plus he's got a neuropathy. Evidence was he's got angle, all reflexes except the angle check, which is decreased, and he has got a claw feet deformity. So he's got a myelopathy, neuropathy, as well as some cortical findings suggesting this is responsible for his visual loss. The clue was that he has got normal fundus, normal reaction, and there is a clue to suspect occipital lobe. So this is a case of adenomyeloneuropathy.
Sir, any mucocutaneous pigmentation in this patient, sir?
No, it was not there.
Yes, sir.
Sir, one doubt.
Yeah.
Earlier it was mentioned that the clawing is suggestive of a non-compressive myelopathy, sir. So can you
No,
just
no,
tell
no.
us? Sir?
I'll tell you, because see, when you got a myelopathy, only pyramidal tract, there should not have any reason for the clawing. If there is a clawing of the feet indicates wasting and weakness of the wasting of the small muscles of the feet. That means there's an element lesion there. The element lesion could be in the anterior horn cell, or it could be due to the neuropathy. So either whether it's an amyotrophy due to anterior horn cell disease, or it's a part of peripheral neuropathy, one cannot be certain. But that's it. That tell you that the lesion is not only confined to the spinal cord. That is other structure is also affecting the neuroaxis. If that is so, it goes for a non-compressive myelopathy. If it's a compressive myelopathy, why should a peripheral nerve or anterior horn cell affecting that area should get involved? And that's the point. So whenever you get a progressive myelopathy, if you have got other systems that are affected, then always consider that possibility of a non-compressive myelopathy. For example, in a progressive spastic weakness, you can optic atrophy, or hypogonadism, or cognitive impairment, or peripheral neuropathy, cerebellar signs, then you think again HSP or HSP variants. That's
Okay.
the truth.
Okay. Sir, one more doubt, sir.
Yeah.
When you mentioned small muscles, sir, regarding in the upper limb, sir, in the hand, is there any clinical condition where you are getting weakness in the palmar interossei, but the dorsal interossei is strong?
Palmar interossei and dorsal is strong. I do not know.
That is, there is a dissociation between, like, when you check the palmar interossei, they appear weak. The patient cannot grip paper between the finger. But the dorsal, that situation.
No, there is in ulnar nerve involvement. The earliest involvement was in the palmar interossei before the dorsal interossei, and that too in the fourth palmar interossei. So some selectivities are when a particular vulnerability can occur in ulnar nerve lesion. But if you find such a pattern, if you find the muscle weakness not fitting with a nerve or a root pattern, as you said in this particular case you said, always keep the possibility of a myopathy in your back of the mind. But in myopathy, it will not respect a nerve or a root pattern. But in myopathy, even it's a distal myopathy, it hardly ever affects the small muscles of the feet or the hand or feet. It always affects the forearm muscles, spare the small muscles of the hand, spares the small muscles of the feet. So if a distal muscle involvement not fitting with the nerve or a root pattern, if the small muscles are affected, you have to think of a more likely an anterior horn cell involvement. There is a localization you have to keep in mind because it's a patchy involvement, not fitting with the nerve, not with the root. And myopathy is possible because of the selectivity, but in distal myopathy, these small muscles are not affected. So that takes us to the localization of anterior muscles. But however, rarely, because of the fascicular vulnerability, some of the nerve lesions can produce an early affection of certain group of muscles within the nerve. For example, in the case of, say, for example, musculocutaneous nerve involvement or anterior interossei, let's say anterior interossei nerve involvement, the only muscle affected may be flexor pollicis longus. The other muscle may be spared. In the sciatic nerve involvement proximally, hamstrings is almost invariably spared. It only affects the distal muscles maximum. So that vulnerability is well known. In the case of radial nerve palsy, producing or posterior introduction palsy, the extensor digitorum or the middle two fingers are affected first. So they come to you with a hand like this. The finger drop for the middle two. So one should not take that into consideration, telling there's only anterior constant because it's a patchy movement. So such vulnerabilities are vascular vulnerability is known in peripheral nerve lesions. But when you get when you say there's only palmar intrusion, not dorsal intrusion, the first possibility should go for anterior constant.
Anterior console, sir.
Yeah.
Okay, sir.
Okay, this is the T1 weighted, and this is the sagittal cut showing the hyperdensity in the occipital. Pardon? Okay, shall I go to the next case?
Yes, sir.
This is from the literature, the MRI picture. I think it's all of you know. Just 2-3 words about adenomyeloneuropathy. It's an adult variant of X-linked adrenoleukodystrophy characterized by ABCD1 gene mutation. And the clinical presentation age of onset is mean 28 years. Progressive spastic paraparesis beginning in the distal lower extremities with hyperreflexia, impaired vibrations and sphincter dysfunction. Patients can also have adrenal insufficiency. MRI findings spinal cord atrophy as in our patients, mostly thoracic. Local focal T2 abnormality may occur, which may relate to indolent cause of the disease. Sorry, the hyperdensity may not be there because of the slow progression of the spinal cord disease. The brain cerebral demyelination may be absent in adenomyeloneuropathy, but sometimes can be confined to the white matter tracts and or diffuse depending upon the supply. Okay, this is from the literature in adenomyeloneuropathy patient. Okay, then I'll go to the another case.
Sir, any specific explanation for peritrigonal early involvement, sir?
No idea. No. In the adrenal sometimes it's predominantly occipital, sometimes it can start frontally also.
Sir.
It can start with frontal lobe and go posteriorly.
It's a frontal variant of adrenoleukodystrophy.
Yeah, frontal variant is adrenal.
Thank you, sir.
Shall we go to the next case? Okay.
Sir, one question. Suppose in the visual acuity, can we differentiate it from the occipital lobe, anterior or the posterior visual pathways? Is it?
The only way to do, if it is due to say there are I'll tell you one condition where you find everything is normal in the fundus. Pupil rate is normal, fundus is normal. Still, the anterior pathway is a CAR. CAR means carcinoma associated retinopathy. You may find normal fundus. Only ERG will be abnormal because the abnormality may be the selective involvement of the retinal, the rods and cones. Otherwise, most of the conditions in anterior visual pathway differentiate from occipital lobe is the pupillary reaction. Then fundus appearance. If everything is normal, you have to think of an occipital lobe. That's the first localization.
Okay, sir.
The other condition which you can mistake is that in acute bilateral retrobulbar neuritis before the optic atrophy sets in, can be confused if it is incomplete vision loss, where the optic atrophy may not be setting in, one may appear normal, but the involvement is violent. But that is only the acute onset presentation, not chronic conditions like this. A chronic vision loss due to optic nerve invariably will have fundus optic nerve optic atrophy there, or retinal lesion means retinal abnormality will be there in the fundus group, except the one which I already mentioned. Carcinoma retinopathy is one condition where you have normal fundus with visual acuity loss. Okay. Okay. This is a story of a 44-year-old lady. She came with the pain in the right shoulder region, increased elevation of the arm. She came to the OPD. On examination, she had periarthritis of the shoulder. So she was also noticed to have, when I examined, she never complained. When I examined, I noticed some wasting and weakness of the right hand. But that is not the complaint by which she came. She complained of pain in the shoulder joint. Then I asked her what happened to this hand. He said it has been there for the last 3-4 weeks. It never bothered her. She never complained. There is no disability due to that wasting. So then I told her that I'll treat you for the pediatritis now. You come for a detailed workup later on. Because she's not allowing me to examine properly because of the pain in the right shoulder. So she was treated for pediatritis and asked to come for detailed evaluation after the shoulder pain has subsided. But she came early, came for follow-up after 10 days before the time scheduled for her to come back. She said she could not complete her physiotherapy because she developed neck pain while doing the physiotherapy. So I started examining in detail. And this is the examination finding. The shoulder muscles deltoid were normal, Sterling test was negative. Biceps normal power bilaterally. Normal. Triceps is normal on the left side, but weak on the right side. The wrist extensions were normal, but the wrist finger flexions were weak. And the weakness is more for the medial to finger. That is able to elevate. The medial is more weak compared to the lateral two fingers. Finger flexors were normal, almost normal. A mild weakness, very mild weakness. The finger abductors were normal, weak, but more weakness for the abductor digit minime than the FTI. The palmar index were also weak. The abductor pollicis brevis was weak. With the reflexes, biceps supinated normal. Triceps was well elicited on the slightly brisk on the right side compared to the left. Left was just elicitable, hardly elicitable. But right triceps was slightly brisk. And there is wasting on the triceps on the right side. The finger pressure reflex were absent by that. Feet was normal, no preventing. Sensations were all normal. So I'll go back to the findings once again. I'll tell the findings. Tone normal in both upper and lower limb. Wasting of the right triceps. Very mild wasting of the small muscles of the right hand. And the findings, motor power examination, the findings are confined to the right upper limb, left upper limb, and both lower limb. Right deltoid, biceps normal power. Triceps grade 3 plus power, which you already seen. Wrist extension flexion grade 5. Finger extensors and flexors are weak, but marked weakness, very mild weakness only for the finger flexors. Main weakness was for the finger extensors. That too, grade 4 plus for the flexors and grade 3 plus for the finger extensors. And the more weakness for the fourth and fifth fingers of extensors. All small muscles are weak. ADM was more weak than the FTI. Left upper limb, both lower limb normal. DTR, both upper limbs, the process normal. However, triceps jerk was better elicited on the right than the left. Both finger flexion reflexes were not elicited. Lower limb reflexes normal, plantar downgoing, sensations normal.
So the duration of symptoms, sir?
Duration is, in fact, she came to me about 6 weeks. Because she said the weakness she noticed about 3 weeks prior to the first complaint of his shoulder pain. So must be around 6 weeks. She came to me after 10 days. I mean, altogether about 1.5 months. If you want to see the clarification, yeah, please.
One possibility is the multiple motor nerves involvement in the right upper limb.
Yeah,
the second possibility is an anti-Horn cell disease, but the duration is short and triceps is wasted with the brisk reflexes favors the anti-Honsel.
Correct, correct.
It's not in a nerve, not exactly in a nerve distribution,
Yeah.
not
So
also in a radical distribution.
okay, very good. So let us consider nerve distribution. What is against a nerve distribution?
That the wrist extension and the finger extension both are totally dissociated.
Okay, that can occur if it is a posterior nerve also.
But then the triceps, but the triceps is
That's the point.
zero extensions.
Yeah. Yeah, you have to say that the triceps is weak, however, the wrist extension is normal. So that cannot be with the radial nerve pulse. That's the point you have to say. So that's against a nerve pattern. Okay. Then what about radiculopathy?
Radical also
T7,
same. Triceps.
Yeah.
wrist extension is also.
Radiculopathy, what is against a C7 radiculopathy?
C7 wrist extension is also C7.
No. See, wrist extension is actually C6. The dominant root value for that wrist extension is C6.
Okay.
C7 contributes.
Sir, it is more of
Triceps is brisk, sir. Triceps reflex is brisk.
Yeah, triceps is brisk. Yeah, this is correct.
Wasting with
wasted also. There is wasted also. Wasting is there in the triceps also.
Wrist flexion is C7.
Wrist flexion is C7.
Yeah, that's right.
So there is wasted triceps with the wrist reflex is against radiculopathy.
Yeah, correct.
So we have to bring the localization to the spinal cord.
Yeah.
Maybe multiple segments are affected. Some of the segments, the anti-Honsel involvement is there with loss of reflexes. And the triceps is weak. At the same time, there is a wasting as well as the reflex is brisk.
Yeah.
So it must be above that, above C7. High up. So with the involvement of the under roots.
If it's above C7, how to explain the wasting of the triceps?
This has to be some with anti-Honsel must be affected. And the corticospinal must be affected as well as the anti-Honsel must be affected.
Okay. So you can consider the possibility of a motor neuron disease you want to keep in mind?
It may not be motor neuron, but maybe some some ischemic myelopathy or some
Venous.
Okay.
Sir, why can it be plexus, sir?
The plexus part again you can explain because of the patchy involvement. You can explain. That's not anything against a plexus involvement. Again, is it not odd that a plexus lesion produce wasting of the triceps and spare the wrist extension?
No, disease is progressing. So initially, now maybe after some time it might reach.
But that disparity is gross, no?
Yes, sir.
Sorry,
triceps reflex is brisk also.
Sorry, one intramedullary relation with the cord compression above.
Yeah, again the same. That's a possibility. Again, we expect triceps reflex to be diminished. It is slightly brisk. The affected muscle should be diminished in intramedullary relation. And the dissociative anesthesia is not that may not be there all the time.
So still, why it can't be the patchy nerves involvement, sir? Patchy in multiple nerves involvement.
That is a possibility, theoretically possible. So you have to think that the part of the radial nerve supplying the triceps is affected. The part of the nerve supplying the wrist section is paired. That's a little odd, but theoretically possible, but not very, and only confined to the right upper. Not in any other part of the body. So the monoiris multiplex pattern is little odd. And no sensory also.
And that can explain the plexus now, sir. Plexus multiple patchy involvement of plexus.
The same point Bindu also was telling like that. Plexus is a possibility we can keep in mind. The odd thing is usually plexus is the reflex will be diminished. It is slightly brisk.
So it is very unlikely to be in the nerve roots or in the plexus. This has to be high up.
Yeah. Right. Okay. Right. I'll go back to the video once again. Now you can. Okay. So what, before that, we're going to before that. So what investigation you want now?
MRI.
MRI. So this is MRI. This is E5 segment, C5, C6, C6, C7, C7, D1.
Lesion high up, sorry. It can still be high up, maybe in the CV junction or maybe C1, C2 level.
That 5-6, can you show once again, please?
Okay, this sort of case I have shown many times in this forum before. Now I'll come back to my video once again. Just concentrate on the video.
Sir, if there is a myelopathy, then the lower limb reflex also should be placed, no?
Yeah, but there can be sometimes self-need can occur. I'll come to that point. Before, see very carefully the distal muscle examination. That part I skipped. No, the restriction is normal. So look at the finger extensions. The maximum weakness is the medial 2 and not on the lateral 2. That part, that is good. But that is main marked weakness. And the ADM was more weak than the FTI. That is good.
Indicates a cord.
What do you call that hand?
Myelopathic hand.
Myelopathic hand.
That's a myelopathic hand. So it's a medial 2 fingers are maximally affected, both extension as well as abduction. Okay. The adduction of the little finger is grossly affected, and the abduction. I'll show that part once. Just one minute. See, you look at the finger abducted. See, the adduction of the little finger is hardly any. That's the thing again. So, as Umma said correctly, it is the lesion is in the high cervical cord. So this is high cervical cord. What do you find there? Lesion is between C3 and C4, C5. That's a large discompression in the cord. Did you see that? I'll show the axial cut also. Where is the axial cut? This is the axial cut. See C4, C5. See the large disc. See, cord is only this much. This is a disc. Whole thing is a disc. This is the disc. Now you may ask why the lower limb is not affected. Difficult to explain, but this is one of the presentations. See, cervical cord, high cervical myelopathy can have various types of atypical presentation. One such thing is this. Then you may ask why there is a wasting of the triceps with that level. You don't expect a wasting. Now this is again described by the affection of this distal ischemia, stagnant hypoxia, which can affect the distal muscles and can go approximately as high as the scapular muscles, as cervical cord. It is not the usually what you have described as only wasted hand due to ischemic myelopathy, but it can go up to the proximal muscles. Now here the myelopathic hand, there is no hardly any wasting in the small muscles. Okay, and that is due to pyramidal lesion and not due to the element lesion. It mimics element. Then you may ask why pyramidal lesion should produce patchy involvement of the medial 2 fingers. But if you look carefully, that's not fitting with the nerve or root because the affection is extension as well as abduction of the adduction of the fingers. They are affected by the middle 2 fingers. Again, that is odd for any nerve or a root. And this is a peculiar pattern. I'll come to that. So, what is this myelopathic hand is? The first abnormality is inability to adduct the little finger. So, the finger goes into abduction position. This progresses to affect the ring and middle finger. That's called the finger escape sign. As the disease becomes more severe, this loss of adduction of the ulnar fingers was followed by inability to extend them, despite lately well-preserved function of the wrist, thumb, and index finger. These abnormalities are associated with pyramidal features in both upper and lower limbs. Sensory loss can occur in the distal upper limb, not in the distribution of any nerve at all. Sensory loss can also occur over both limbs, depending upon the degree of compression. Lesion is in the high cervical cord. See in the cervical cord lesion above C6, C7. Remember that this is The myotomes applying is C8 and C7, C8. But the lesion is seen above C6, C7 and can be seen in lesions up to foramen magnum. That indicates a disorder of the upper motor neuron and lower cervical spine. There is no correlation between the myelopathic hand and the level of the lesion of the cervical cord. The lesion response of the myelopathic hand is due to the degeneration of the cortical spine. This is also proven pathologically, since the anterior horn cell of the gray matter of the C6, C7, D1 are generally well preserved. This is the explanation given for the very funny explanation. Anyway, I can give that explanation. The learning point is that upper cervical myelopathy is confessed with the unusual pattern of motor weakness in the hands. One such is a myelopathy. Other thing is that the motor atrophy of the hand, they can have numb clumsy syndrome. Is not a typical presentation of upper limb. They can start only with the numbness of the medial or the ulnar, the little finger, as all of you know. Anytime we have stressed that point in the discussion. Okay, any points trying to clarify here?
So what about the posterior column sensation, the little fingers in this case?
This case was normal. Because the posterior column is not affected. It's mainly compressing the anterior part, compressing the pyramidal part.
Why there is no left-sided involved in this case? So because the spinal cord is such a crowded structure, so why we should have...
Right. It is compressed right side more than the left side. But if you look at the compression, it is bilaterally it is there. But clinically, her right hand is only the one affected. That is the funny part of it. And if you want to see the follow-up, I think I did not show the follow-up. This is the follow-up MRI of the patient after surgery. Price has become normal. The finger has become good power. It's also good power. It all become marked improvement. That proves the point that that disc is responsible for the so-called myelopathy hand.
Sir, one doubt, sir.
Yeah.
Sir, like even L4, L5 radiculopathy, more patients will tell the symptoms on one side, but surprisingly, we will see more narrowing of the root on the opposite side, sir. Is there any explanation for that, sir?
No, that you can't explain by a root lesion. Narrowing on the left side producing right side involvement. That you cannot explain. That means you have to invariably look for any other cause for is that so-called L5 L4 radiculopathy. Was it actually L4 radiculopathy, or there is a lesion above, or causing the L4 radiculopathy, or maybe totally not a radiculopathy, maybe a neuropathy, like a sciatic neuropathy, or that you have to keep in mind.
Okay, sir.
Because that you can't explain. If a compression is there on the left side,
yes,
you cannot get the lesion. So in that case, carefully screen the spine up. Take the imaging up to the epiconus region. There is a lesion there you have to look for on the right side. Many times this happens. Many times this, I also had gone wrong many times. You think of a radiculopathy and then you find some disc there on the other side. We may think that that is maybe there's small disc there. But on follow-up, you find the lesion is entirely different, maybe in the context also.
Sir.
So you have to carefully follow up that patient. Don't think that that disc is causing the problem.
Okay, sir.
Then one doubt.
Yeah.
So this triceps wasting is, you said it is because the anterior horn cell due to the ischemia to the anterior horn cell.
Yeah.
But brisk is due to the high cervical cord.
Yeah, correct. That is why in remote atrophy, when you now this is also a good point that Bindu brought about. See, when you come to the come across a patient with the small muscle wasting in the hand, and you find that reflex is well elicitable, always keep the possibility of a high cervical cord compression, because that can occur with a C8 even radiculopathy or neuropathy or anticondylar disease, pure anticondylar disease. But if the reflex is preserved or brisk, think that it's a remote entry. That means there is a superadded pyramidal lesion above. And this wasting is due to the stagnant hypoxia due to a lesion above, compression above.
Thank you.
But there is also another point. See, even in a high cervical cord compression, you can have absent reflex in the dissociative anesthesia and absent reflex in the hand also. That is again because of the ischemia to the central part of the cord, where the reflex carrying fibers are affected centrally, not because of the compression of the root.
Okay.
So that kind of different presentations are known. Did you get the point, Bindu, what I said?
Yes, sir.
Yeah, because the
Then-
ischemia, the stagnant hypoxia is causing ischemia to the anterior console. That is the central part of the cord.
Yes.
The central part of the cord is affected little more. It is going to cut off the reflex carrying fibers.
Yes, sir.
C8 reflex carrying. So you get an absent reflex. So one may erroneously think that the lesion is purely LM and confined to that area. Just purely, we should consider that possibility, but rarely this can occur in high cervical. So if any evidence of any pyramidal lesion above, like spasticity in the upper part or a brisk reflex in the upper part, keep this possibility in the back of the mind.
Yes.
Syringomyelia-like presentation.
Yeah, syringomyelia, exactly, syringomyelia presentation. This second on the literature one, myelopathy hand. Okay, shall I go to the next case? Okay.
So can we get similar picture in motor neuron disease?
Yes.
Wasting with the preserved reflex or increased
Yeah,
reflex?
absolutely, perfectly right. Absolutely. You can have this picture, this patient, one of the DD should keep his motor neuron disease. Okay, but the clue was he had a root pain. The patient came to me with pain in the shoulder, radiating down.
So is this the reason why in motor neuron disease that criteria says that you should have a human lesion below the element?
Correct, perfectly right. But the problem comes now when the patient comes to you first, before developing all the days. If you wait for the criteria, then you can't diagnose. So suppose this patient comes to you with a normal MRI, with no sensory, and wasting and weakness in the patchy distribution. What else could it be? Difficult, no? Second anterior console disease you have to keep.
Yes.
Arnold GRA will present like this. Is there a question?
Yeah, any high cervical cord.
Series.
Yeah, any compression can cause that. Okay. Shall I go to the next case?
Yes, sir.
Okay. It's a story of a 70-year-old man who presented with acute onset of dizziness and difficulty in walking for the last 3 days. No dysphagia, no sensory complaint. This is the patient. He had, in fact, a slight head tilt to the right side, but that had been correct.
ഇനി മുകളിലോട്ട് നോക്കിക്കേ.
Ocular muscle examination. Upward movement is normal. Downward movement is normal.
That's good. മുകളിലോട്ട്.
But you see there's some asymmetry in the eye position. Look into the left side, there is a fast beating nystagmus to the left side. It's fast component.
It's got everything rotary
On
nystagmus.
looking to the right side, he's got a rotary nystagmus, which I don't know whether he'll be able to make it out.
Look at left
Left
side
side
is
is
horizontal.
beating to the left side, which you can make out.
Right side.
But right side, there is no side beating nystagmus. But there's a rotary component.
See the rotary nystagmus.
Rotary component to pass towards the counterclockwise direction. Then you can look at the eye position. The left eye is slightly up compared to the right.
Correct. Left eye is up compared to left eye is down compared to left side. In all directions. Okay,
Pupil ratio is normal. There is no Horner syndrome. Rest of the examination is normal. Motor system normal. Reflexes normal. You need to check for the fingernosing coordination. There is no fingernosing coordination. No heel shin test is also negative. You did perfectly well.
ഇനി ചെയ്തേ. ഇനി ഈ കാല് ഇനി അതേപോലെ ഇടത് കാലം കൊണ്ട് ചെയ്തേ. പൊട്ടിച്ച്. ശരി.
The reflexes are all normal.
മുട്ടൊന്ന് മടക്കിക്ക്. നീട്ടി വെച്ച്.
Plantar was ongoing.
ലൂസായിട്ട്. ഇതും ഒരേപോലെയാണോ വ്യത്യാസമുണ്ടോ?
Same on both sides of the
ഇത്
face.
ഒരേപോലെ.
Same on the body and the limbs. But when he's standing, he falls to the right side. See? He's pushed, he is falling towards the right side. Walking is okay, fine, but again straight to the right side. So any point you want to clarify, you want to see the eye movement once again, I will just show that.
Sir, is one clip where the upward gaze is showing some abnormalities, zigzag. Can you show that, sir?
Upward gaze movement. You mean restriction?
No, sir, the upward gaze.
Yeah. I'll show one second. At the very beginning, I will show.
ഇനി മുകളിലോട്ട് നോക്കിക്കേ. താഴെ നോക്കിക്കേ. ദാറ്റ് ഇസ് ഗുഡ്. മുകളിലോട്ട് ഇവിടെ നോക്കിക്കേ. ഒന്ന് നോക്കിയേ. ഇവിടെ അറ്റം നോക്കിക്കോ.
Probably you may not be able to see the Rotary Nystagmus.
ഇടത്തോട്ട്.
But peeking to the left side.
Left side is horizontal view.
That you can see.
Right side.
Few beats of the Rotary Nystagmus.
അറ്റം നോക്കിക്കേ.
Look at the position of the eye. Left eye slightly up compared to the right.
Left eye is up compared to the right. Down compared to the side. In all directions. നോക്കിയാലും മതി. I want to.
No horns.
ഇത് മടക്കിക്കേ.
No limb power, everything normal. Like the heel shin also is.
ശരി. ഇനി ഇത് പൊക്കിയിട്ട് എൻ്റെ വിരലേ തൊടണേ. വിരലേ തൊട്ടേ. ഇനി ഈ കാല് ഇനി അതേപോലെ ഇടത് കാലം കൊണ്ട് ചെയ്തേ. പൊട്ടിച്ച്. ശരി.
It's just normal. I will skip down those things. I'll show the gait.
ഇതും ഒരേപോലെയാണോ
Sensations normal.
ഇതും ശരി.
You are making stand. He's pushing the person to the right side. Okay. Sorry, my power went off. I'm going to restart. Screen visible now?
Yes, sir.
Yes, sir.
Okay. So these are the findings. Body head tilt to the right side. Before that, what are the findings in this patient? And where do you think is the site of lesion?
There is a skew.
Yeah.
Right
Skew.
lateral medulla. There is a skew with the right eye lower down.
Or left eye up.
Or left eye up. But considering that the fast nystagmus is to the left and the patient is falling to the right, probably the right lateral medulla is involved.
Okay. Why can't be left midbrain lesion, left pontine lesion after crossing?
Then left midbrain.
Pardon?
Midbrain, there is no vertical movements or normals.
No, the thing, what is he having? He has got a skew deviation with left eye up or right eye low. That means that the lesion is in the graviceptive pathway from the ocular connection. It may be on the right side of the vestibular nucleus connection of the right side, and the right lateral medulla, or the pathway is affecting after crossing. After crossing, it ascends in the MLF to the or to the third and fourth nucleus in the midbrain.
Yes, sir.
If it is after crossing, you get a left eye is up.
Yes, sir.
If it is before crossing, the right eye is down. Okay. So it can be this kind of picture. This skew can occur with either a right lateral medullary lesion or a left pontine lesion after crossing or left midbrain lesion.
Lateral pulsion is in favor of a medullary lesions.
But lateral pulsion can occur also with pontine and midbrain lesion. It's again a disorder of the graviceptive pathway. No? In midbrain lesion and pontine, you get a contrapulsion.
No other
pupillary thing is not
no long tract signs.
No long tract signs in this. No cerebellar signs, no pain, pain loss, no dissociative anesthesia. Corneal lupus is normal. And pupillary. Nystagmus is there with fast component towards the left side.
Yes, sir.
So we look for accommodation.
Accommodation, I don't know whether done or not. By accommodation specifically, you want to look for what? Any pupil reaction is no. I think the accommodation may not give any additional help.
Sir, isolated vestibular with no much cerebellar. The cerebellar has to be involved in the midbrain, the parts, because it's very closely tightly packed. So without the pyramidal tract involvement, without the cerebellar involvement, without the pupillary involvement, it is very unlikely to be in the brain or the pons on the left side.
I think Bindu, you got some echo coming from your speech. Can we a little more closer to your mic and then speak? So you want to consider, you may have to think of a midbrain lesion?
No. Lateral medulla, right lateral medulla is my localization. Why? Because the midbrain and the pons. If it was in the midbrain and the pons, there was no pyramidal signs in the patient. There is no cerebellar signs.
No. See, that's the same thing I can argue for a right lateral medullary syndrome. He has no right cerebellar signs. He's not there. He has no pain, no decreased pain on the right side of the face, no Horner syndrome, no pain loss on the left side of the body, no limb incoordination is there. And in the pons and midbrain, the lesion is in the tegmentum, not in the ventral part. So this MLF and all situated in the dorsal tegmental region.
Yes.
Where there is no pyramidal tract.
Yes, sir.
You may get a nystagmus in that case. This type of nystagmus, if it is a pons or a midbrain lesion.
Rotatory nystagmus with a fast component away to the side of lesion. This is right vestibular involvement only, will produce that kind of.
Okay.
We have a rotatory on this ipsilateral side, on the side of, and the fast component towards away from that side is usually the vestibular.
Right. What do you call that nystagmus? It's something mimicking a peripheral vestibulopathy, no?
Yes, sir.
Yeah.
But it is
It's called-
not peripheral.
Yeah.
Because of the skewed
Pseudo-vestibular.
we always
Very good, very good. Pseudo-vestibular, you're right. It's correct. This I told last time. So let's see. These are the findings. Horizontal jack nystagmus to the left as well as primary position, but less in the primary position. Rotary nystagmus in the right time. This is my question. So, do you want to look for lateral saccadic lateral position?
yes, sir.
That also not going to help in this patient. Why?
Because the vestibular is anyway involved. If the
No. The saccadic lateral position means you can, if you get an inferior vela cerebellar putting on the right side, you get ipsy-pulsion. Okay, right ipsy-pulsion. But superior cerebellar putting in the contralateral also will produce a pulsion to the opposite side. Suppose this patient's got a pulsion to the right side, it may indicate a lesion on the right medulla, or after crossing in the left pons, the left membrane. Superior cerebellar putting on the left side. That is where the bundle of Russell is coming. Probably I told you last week about that pathway. It's difficult to remember
you
that
talked,
pathway.
yes, he told this.
Yeah, so that can differentiate. So let us see the saccadic lateral pulsion in this patient. He has got pulsion towards the right side. Okay, so it's got a saccadic lateral pulsion to the right. May indicate at left medulla or left lesion. Okay, the point is the pseudo-vestibular nystagmus that cannot occur with a described with a medullary lesion with the vestibular nucleus connections. So vestibular pseudoneuritis is caused by central fascicular lesions to the vestibular nerve or vestibular nucleus or vestibular cerebellum, most often due to ischemia or inflammation. This is to differentiate from peripheral. Then, what are the types of nystagmus and lateral medullary syndrome? Nystagmus and lateral medullary syndrome may be due to direct damage to vestibular nucleus or their cerebellar, semisecondary canal or otolithic connections. Usually positional and can be horizontal, torsional, and mixed with torsion, vertically horizontal components. Torsional nystagmus is common in Wallenberg syndrome with upper poles of the iris beating away from the side of infarction. Now, why this? What is the pathophysiology of this lateral pulsion? Why the patient is going to this side? No, there is it's a very closely mimicking condition. Can you tell me where the patient pushed to opposite side of the lesion? Here he is pushing to the same side. He is falling towards the same side. There's another condition where you find in a hemispherical lesion or thalamic lesion, the patient will push himself to the contralateral side, the side of hemiplegia. That is called the Pusha Syndrome. Have you heard of the Pusha Syndrome? Pusha.
No, sir.
Okay.
Yes, sir.
Yeah, that is same hemispherical lesion. That is because of the vertical orientation is defective. The perception of the vertical orientation is defective. Okay. Now here in lateral medullary syndrome, or the body lateral pulsion occurring in the pontine lesion, midbrain lesion is due to the what is called the abnormality in the due to the tilt in the subjective visual vertical. That means the subjective visual vertical is because of the orientation of your body and eyes and head neck relation to gravity mediated by the otolithic pathway, which is getting connected to the induction nucleus of Cajal and the extraocular nuclei. And the pathway also goes to the thalamus and to the cortex. I think I'll skip this point. This is the pathway. See, this is the otolithic organs getting connected with vestibular nuclei, cross to the opposite side and ascend to the nuclei here and then to the thalamus and to the parietal cortex. You can see the person's tilt, no? The lesion here or the lesion the opposite side all will produce a tilt. But if it is before crossing, it is tilted to the same side. If it is after crossing, tilted to the contralateral side. That is a pulsion in this particular patient could be due to lesion in the right lateral medulla or left after crossing. This is another case. The patient had a contralateral opposite pulsion to the opposite side by a pontine lesion confined to this area. That's from literature. In medullary lesion, the subjective visual vertical is before crossing, so it's ipsilateral to the side of lesion. In pontine and lesion above, it is to the opposite side. There are also other explanations for the lateral pulsion. Now, why in this our patient, there is ipsipulsion only confined, ipsipulsion without any limb ataxia?
Limb ataxia is neocerebellar, no sir. That is not affected. It's a vestibular cerebellum, sir.
That limb ataxia can be inferior subepidemial involvement. Inferior subepidemial also produces limb ataxia. That is like a limb ataxia in lateral medullary syndrome, the inferior cerebellum. So this is another interesting fact, which in fact I did not know. I only read yesterday. It's called isolated axial ipsipulsion. In our patient, this patient had no Hilshin ataxia, no finger nose incoordination. Only the trunk is so much tilted. You see, it's so much of tilt to the right side. Isolated axial lateral pulsion occurs with ischemic lesions, the inferior part of the cerebellum and tonsil, and with the with either due to demagnetic lesion, the superior or inferior subepidemial. Body lateral pulsion without limb ataxia was probably due to the impairment of the vestibulospinal postural control caused by lesion in the descending lateral vestibulospinal tract. See, it is here the what is called the aortic prostate is there. It is the involvement of the descending vestibulospinal tract, so that the posture maintenance by the contraction of the extensor muscles are affected on the same side. That is why you get a tilt towards this one side. There is no limb incoordination because the cerebellar peduncules are unaffected. Now, body lateral pulsion with limb ataxia was attributed to lesion the ascending dorsal spinal cerebellar tract. Now, this is the lateral. This lesion is confined to this area, which is marked in red. That is the lateral vestibulospinal tract is responsible for your isolated lateral pulsion without any limb ataxia. To limb ataxia to cause the lesion will be more posterior, affecting the inferior cerebellar peduncle. This classical lateral syndrome is posterior. Here it is anterior. That is why there is no all other pain. These are the descending nucleus trigeminal and all. They are all spared nerve patients. No Horner syndrome is here. The dorsolateral part, which is classically involved, is not affected in this patient. It is affected on the mid-lateral part of the medulla. This is the explanation. The lateral vestibulospinal tract is considered to play an important role in the maintenance of posture by exerting strong excitatory influence on the extensor muscles and inhibitory influences on the flexor muscles. Thus, interruption of the lateral vestibulospinal tract decreases the extensor muscle tone of the trunk and lower limb on the side of the lesion, which is likely to cause the ipsilateral axial lateral pulsion. I think I'll skip all the things in this patient. In this role, I will skip. This is the tilt to the subjective vertical, how you live. This is the Pusha syndrome. I think I will skip that thing. This is the Pusha syndrome. Here the patient's got a right thalamic lesion. He actively pushes towards the paralyzed side. Pushes towards this girl. The lesion is on the right side. Right thalamic lesion. And this is because of the person perceived that is tilted to the normal side. So when you open the eyes, it corrects and pushes to the opposite side. Try to correct and push it to the opposite. I think we'll skip all those things. Okay, any questions in the previous case? Where everyone has become silent so suddenly.
So the isolated rotary nystagmus, what will be the cause in this case? Vestibular spine.
That is the connection between the vestibular nuclei to the extraocular nucleus affected. See, if you get isolated rotary nystagmus, what is if you ask me what is the pathophysiology of isolated rotary nystagmus? It is because of the affection of the superior and inferior semicircular canal. Their connections are affected without affecting the horizontal canal. Because if those pathway coming from the anterior superior canal are affected, it produces only the rotary compound will become manifest. Suppose imagine my right labyrinth, superior canal or inferior canal, or its connections are affected. It is unlikely to occur with a peripheral lesion. How can a peripheral lesion produce only superior inferior cervical canal? That cannot occur. The only possible, the fibers coming from there is affected with the brainstem. So when you get a pure rotary nystagmus, always think of only brainstem central lesion. So in fact, both superior and inferior cervical canal produce a rotary slow component to the contractile side. The corrective component is to the same side. They produce a pure rotary nystagmus. Only superior canal is producing an upward eye movement bias. Inferior canal posterior canal produce downward movement bias. When both are affected, the vertical bias is cancelled out. The upward bias and the lower inferior bias is cancelled out. Only what remains is the rotary component, which is same direction whether the superior canal or inferior canal is stimulated or canal is inhibited. Inhibited means the opposite side is overactive. That is, you get a pure rotary nystagmus. If you get a complete labyrinthine involvement on one side, say for example, cut off all the semicircular canals, what you will get will be horizontal rotary nystagmus. Rotary nystagmus is because the superior inferior canal involvement. Horizontal because producing a horizontal eye movement. So it is horizontal rotary nystagmus. That is a classical peripheral nystagmus. There is a pure rotary, pure vertical, whether upbeat or downbeat, always it is central, never peripheral. If it's difficult for you, then I can take, one day I'll take the class on this vestibular connections and the nystagmus, how it is produced.
Yes, sir.
Yes, sir.
Okay,
Please,
sir.
sir.
Yes, sir. One day.
Yeah. This is also very interesting, the one which the Pusha Syndrome, I did not want to talk about this thing, but this is also very, very interesting phenomenon. Here what happens is that when the patient's eyes closed, he thinks that his body is tilted to the, when he keeps his body tilted to the one side, to the normal side. But in his mind, he is vertical. He is standing, according to his, when he is closed eye, he sees he's vertical. He's vertical. The gravity, the gravitational orientation is vertical. But actually his body is tilted to the normal side. When you open the eyes, what happens is that he sees that the environment is tilted. So what will tend to overcorrect to the opposite side? That is push towards the opposite side, to the lesion side, and not to the paralyzed side. See, body, he feels his body tilted to the normal side, not feel. When the body tilted right side, then only feels his verticality, with the eyes closed. When he opens, you find a mismatch between what he perceives the environment and what his body orientation is. So he tends to correct it, make it vertical. See, the attempt to vertical, he pushes to the opposite side. That is the pathophysiology of this Pusha syndrome. Okay. So shall we stop here and go for one more case?
So
We'll go, sir.
You
We can
didn't
continue. We can
ask me
continue.
where is the cytolation in this patient. He had a medullary infarct. He got a lateral medullary infarct, dorsal to, the midway between, not the classical side, little anterior to the classical side.
So the Pusha syndrome is not due to the the explanation for the pulsion in the medullary lesion was imbalance in the vestibulospinal tract, no sir?
In Pusha syndrome, It is no in the classical medullary lesions producing lateral prosenol, it is due to the effect on the vestibular connection of the extraocular nuclei. That is to the so-called ocular tilt reaction.
Yes.
That is due to the affection of the autolytic pathway getting connected to the visual nucleus, then cross the opposites in the MLF and getting connected to the induced nucleus accumbens, which connected to the extraocular nuclei. And some of these fibers go to the thalamus and the parietal lobe for your perception of the subjective visual vertical. That is called SVV. So the SVV is affected in the otolith, this vestibular connection movement. In the case of Pusha syndrome, it is not SVV is affected, the SPV is affected, the subjective positional verticality. That means his perception of the orientation inclination to gravity due to the somesthetic, the sensory input to the brain from the parietal cortex. That gives you an orientation of the verticality in his mind. That is affected. That is why the classical Pusha syndrome is seen in thalamic lesions. Sometimes it also seen in basal ganglia and parietal, but classically thalamic lesions.
Okay.
Where the body orientation is affected.
Okay, sir.
In that patient, there is no nystagmus, nothing. Okay, shall we go one more case?
Yes, sir.
Okay. This 55-year-old patient, who is an old case of depression, she had cut her left hand over the palmar and dorsal aspect of the wrist with a kitchen knife with the intention to commit suicide. This is 2 years back. However, 2 months back, she noticed thickening of the skin over the wound site. And for the last 2 weeks, she noticed numbness of the left palm and weakness of the left hand. Okay. Right. Now go to the examination. The third was normal, biceps normal. You see, this is the cut side where you can some swelling is there. Right, swelling is there on the side. Examining text about this thing is protective policy brevis was weak, longus was normal, brevis was weak. That is weak.
Okay,
Extensor pollicis longus is normal. But extensor pollicis longus is longus and brevis is weak. That is weak. Weak. That is normal power. Pressure with normal right side, but then weak on the left side.
ഇനി ഇത് ശ്രദ്ധിക്കണം, ഇതിങ്ങനെ പൊക്കിക്കാൻ ഇങ്ങനെ പൊങ്ങിയിരിക്കണം. പിന്നെ ഇതിങ്ങനെ പൊക്കിക്കാൻ ഇനി ഇങ്ങോട്ടാക്കിക്കേ. കൈ നൂർത്തി നൂർത്തി പിടി. ഇങ്ങനെ പിടിച്ചു ഇങ്ങനെ ഇരിക്കണം. പിടിച്ചു വിട്ടോ. ഇതിങ്ങനെ ചേർത്ത് പിടിക്കും.
Look at the finger. The middle finger was maximum drooping down. So examine the finger exercise. Yes, all way weak. The maximum weakness was the middle.
അത്രേ പൊങ്ങുന്നുണ്ട്. ഇത് പൊങ്ങിക്കമ്മ. ശരി, ഓരോ വെള്ളമ്മ പൊക്ക. പൊക്കാന്നിടത്തോളം പൊക്കിക്കേ.
That is maximally weak.
ഇത് ഒട്ടും പറ്റുന്നില്ല.
That's little more power. That's little more power.
Okay.
The reflexes are all normal.
ബലം കൊടുക്കരുതേ. ബലം കൊടുക്കാതെ കളന്ന് കിടക്കട്ടെ.
Normal biceps.
ബലം കൊടുക്കാതെ അങ്ങനെ കിടക്കട്ടെ കേട്ടോ. ഈ കുത്തുന്നതും ഇതും അമ്മയ്ക്ക് ഒരേപോലെയാണ് വ്യത്യാസം.
If there's entire palm, there is some abnormal sensation.
ഒരു വ്യത്യാസമുണ്ട്. ഓക്കെ, ഇതും
Yes,
ഇതും
okay.
ഇനി അമ്മ ശ്രദ്ധിച്ചോണേ. ആ
Yes,
പെരുപ്പ്
very
മാറി
abnormal.
നോർമലായിട്ട് തോന്നുമ്പം അമ്മേൻ്റെ അടുത്ത് പറയണം. അത് മാറുമ്പം അസ്വസ്ഥത മാറുമ്പോൾ പറയണം.
There equation is normal.
പെരുപ്പില്ല. ഇതും
There it's equal on the dorsal aspect.
ഈ കുത്തുന്നതും ഇതും തമ്മിൽ എങ്ങനെയാണ്?
There's not much difference.
ഇല്ല, ചെറിയ വലിയ വ്യത്യാസം ഇല്ലെങ്കിൽ ഇല്ലെന്ന് പറയണം. ഇതും ഇതും
Equal.
ഇതൊക്കെ ഒരേപോലെ ആണല്ലോ. ഇവിടെയൊക്കെ ഒരേപോലെയാണ് വൈബ്രേഷൻ.
It's able to feel vibration.
ഇപ്പോഴോ ഇപ്പോഴേ അറിയുന്നില്ല. ഇതോ ഇവിടെ അറിയുന്ന അധികം അറിയണില്ല അല്ലേ അമ്മ?
Vibration is less on the middle finger.
കുഴപ്പമില്ല.
It's
ഇവിടെയാണ്
also telling some numbness on the middle, dorsal aspect of the middle finger.
ഇനി ഈ കുത്തുന്നതും ഇതും വ്യത്യാസം ഉണ്ടോ അമ്മ?
It's little less on the middle.
ഇനി തള്ളവിരൽ ഇങ്ങനെ പൊങ്ങി അങ്ങനെ
The extensor pollicis longus once
ഇത്
again
പിടിച്ചോ.
is weak on the left
ഒട്ടും
side.
വരണില്ല. ഒന്ന് ശ്രമിച്ച ഇങ്ങനെ വരാനായിട്ട് ഇല്ല. ഇത് വരുന്ന പോലെ വെച്ചാൽ ഇങ്ങനെ വരണില്ല അല്ലേ അമ്മ?
Okay. So I'll go to the findings. Weakness of extensor pollicis brevis, extensor pollicis longus, finger extensors mainly at the middle finger, all small muscles with the left hand with wasting of the thenar and interosseum. There is questions and weakness of the extensor carpi radialis are not very convincing. Detail all normal. Sensory loss of the distal phalanx of the middle finger. She feels abnormal sensation over the entire palm. She says some kind of a funny sensation when the palm is stretched. Dental sign is positive. So where is the localization? If you want to see the video once again, I can show.
So is APB involved, sir?
APB is involved. The hypothalamus is involved. All intuition.
So the involvement of the left medial ulnar and the posterior introsseous nerve at the wrist is one of the possibilities, sir.
In the wrist component, wrist section is normal. Abductor pollicis longus is quite normal, but the finger extensors were weak, but the maximally in the middle finger. The other two, then the relatively well preserved was the, I think the extensor digitae minimi and the extensor of the ring finger. And there is sensory dulling on the dorsal aspect of the middle finger only.
The pin posterior introsseous nerve is involved definitely, sir.
Just one more point. He's got extensor pollicis longus and ribs also is weak.
Yes, the pin is involved on the left side, sir. Other than as the medial and ulnar nerve at the wrist, sir.
Okay. So what do you want to postulate?
Something growing inside the wrist, sir, which is affecting all the nerves.
Okay. Due to what?
Neuroma maybe, sir.
Okay. Right. Neuroma of median nerve, ulnar nerve, and radial nerve.
Maybe one nerve which is affecting all the other nerves.
Okay. Right. But the ulnar nerve, median nerves are the polar side, radial nerves on the dorsal side.
So there is definitely there is a median nerve in involvement.
Yeah.
With the sensory impairment, there's that has to be slightly proximal because the entire palm is affected. So the palmar cutaneous and the dorsal cutaneous nerve of the median must have been affected, with the wasting of the thenar as well as the the small muscles innervated by the median on the right side with the sensory symptoms. Probably there is a
there is also weakness of the odd introshi. Weakness of the ADM is also weak.
Yeah. Yeah. Additionally, the ulnar must be affected. Ulnar is affected.
Okay.
But the dorsal part it has to be more proximal. So I don't know whether you have to think of a more proximal issue.
Very good. Okay, correct. Right.
At the elbow, maybe, sir, at the origin of the No, the median ulnar can be involved.
I didn't get that point. You mean to say the median ulnar at the proximal near the elbow?
Yeah, the origin of the pin, posterior intraosseous nerve, there may be simultaneous involvement of the medial ulnar nerves.
Okay, they're in that area, but there is no lesion there. In fact, she had a cut injury. She had cut the wrist only, just above the wrist, which you have shown, you know. Okay, anyone else would like to make a comment? Anyone?
Can there be a mechanical cause for the inability to extend finger?
Yeah, good thought. What mechanical you think? But he's also got some sensory
Fibrosis, sir. And then there is a fibrosis of the tendons, this extensor. So there can be difficulty too.
Okay, right.
Sir, there must be some hyperesthesia and the pain due to the neuroma. So that must be causing some sort of painful restriction or something.
No, it's not a painful. See, excessive pollicis longus are not clearly weak. There's no pain.
Correct. If extensor pollicis longi is weak, it is not to the nerve, it is due to the tendon. The extensor is that area when it is cut.
Okay.
That cannot explain with the nerve.
Exactly.
Because the nerve to the APL is from very proximal. But rest of the thing we can explain the ulnar and the median. We can explain the a little about the rest, but not the EPL. It is very much high.
Not only EPL, what about the finger extensors?
Yes, finger extensors also. Extensor.
Yeah, there also. So you want to see what is what said is correct. See, you have to explain either a median ulnar easy to explain. You can injure a cut injury in the palmar aspect. You also got a cut injury in the dorsal aspect also. If you see this, I will show that video. See the scar on the dorsal aspect. See the scar on the dorsal aspect. She's cut not only the volar, she also cut on the dorsal aspect. Okay. Now, you can argue that he's got a median ulnar nerve involvement and the radial nerve, but if you want to explain by radial nerve involvement, the lesion has to be proximal. Correct? It should be in the elbow, somewhere in the elbow region that you're all thinking. But again, how to explain it? She had only cut injury there. How can I explain that thing? So again, that's a point comes to your mind, is it loud? So what Bindu told is correct. So what do you want me to do in this patient?
Ultrasound, sir. Ultrasound of for the tendons.
Okay, good. So I did. So what about conduction study?
Conduction radial will be normal, sir.
Okay, let us see the conduction now. The median nerve is affected. Ulnar is, even though it is 4.8, 5.7 is there, compared to the right side, it is decreased. 8.45, it may be partial affection. And sensory left median is obtained. Left radial, no sensory. But left motor is normal. Okay. And she has also got a dysthesia on the dorsal aspect. So what do you want to do? So we did a MRI of the wrist. This is a wrist, but you forget about difficult to make it out. This again at the level of the wrist. Now what you are interested is at the level of the cut. Okay, this is the distal part of the forearm. This is the ulna, this is the radial, and this is called the least tubercle. I will come to that later on. The compartment I will come later on. Now, let's see the report. Thickening of the median ulnar nerve just beneath the scar site with adjacent ill-defined T1 and T2 hypoindented soft tissue showing post-contrast enhancement, possibly post-traumatic neuroma to be considered, as you all correctly said. Thickening of the tendons with extensor carpi radialis longus and brevis, and extensor pollicis longus in the region of crossover. The synovial sheath surrounding the extensor carpi radialis brevis also appears thickened, showing post-contrast enhancement. Possibility of a distal intersection syndrome. I'll tell you what is that syndrome. I don't know any of this. Only after this I read about it. Split tear involved in the tendon of extensor carpi radialis brevis. Thickening of the synovial sheath of the extensor digitorum with mild fluid within and post-contrast enhancement, tenosynovitis. This is the report of the radiologist. Now, what is this distal intersection syndrome? It relates to tenosynovitis of the extensor pollicis longus tendon. There is the third extensor compartment where it crosses the extensor carpi radialis longus and extensor carpi radialis brevis tendons. That is the second extensor compartment. Then you must know what is these various compartments that will come later on. It is distinct from the intersection syndrome, which occurs more proximally in the forearm at the intersection of the first and second extensor compartment. Now, this is the crossing over. You can see this picture here. This extensor tendon which is crossing over the extensor extensor carpi radialis longus and brevis. If there's a tenosynovitis, any one of these, it can have the other tendons also used crossing over. The crossing of the second extensor compartment is typically located just distal to the Lister's tubercle. The tendon sheath, the EPL and extensor carpi radialis brevis are connected by a communicating foramen. This is probably why the inflammation of the extensor pollicis longus tendon spreads to the second compartment and vice versa. This is the crossing over. That's called the distal intersection syndrome, where the inflammation is here. Now, what is Lister's tubercle? Is the tubercle of the dorsal tubercle of the radius is a bony protuberance of the dorsal surface and distal radius. It separates the second and the third extensor compartment. It acts as a pulley for the EPL extensor pollicis longus tendon, changing its mechanical direction. If you look at the extensor pollicis longus tendon, it is the one which goes the centrally and then deviates laterally to the thumb. Now, this is the tubercle. Okay. The tendon goes here and then goes like this, deviate to the right side, and acts as a pulley here. Now, this is the various extensor compartment in the distal part of the forearm. This is a dorsal aspect. This is ulna. This is the first compartment which houses the extensor pollicis brevis and extensor abductor pollicis longus. The second compartment, extensor carpi radialis longus and brevis. Third compartment houses the extensor pollicis longus. Then the extensor digitorum in the fourth compartment, extensor digitorum in the fifth compartment, and laterally extensor carpi radialis. Let's forget about this part. Now go to our patient. This is our patient's corresponding picture. You see the inflammation of the tenosynovitis occurring in the extensor compartment. That is why it is causing this tenosynovitis of the extensor tendon. And also this compartment, extensor carpi radialis longus and brevis. And so the so-called paralysis or weakness of the abductor pollicis, extensor pollicis longus in this patient, and the other middle finger, extensor digitorum of the middle finger mainly, are all due to the tenosynovitis affecting the tendon. And why the sensory loss? Maybe due to the cut injury. It's got a cut injury, no? One of the superficial digitina might have been cut. That is why it's got a dysesthesia or a sensory loss in the dorsal aspect of the finger. That is the effect of that tenosynovitis. So, final diagnosis post-traumatic neuroma of the median, but tenosynovitis for the second and fourth compartment responsible for the weakness of the extensor pollicis longus, extensor pollicis brevis, and finger extensors of middle finger mainly.
Sir, NCS of posterior interosseous nerve was done, sir.
But yeah, it was done. That is normal. Even NCS, no, EMG was to do. That was not done.
Pin, sir, pin.
Yeah, for then your point is valid. We can, in that case, we have to take the lesion high up, no, near the elbow. But we can explain everything by the cut injury on the dorsal and palmar. That's again the logical thing. Logically, we expect, no, you have a cut injury there. We have to explain why that. How can the cut injury cause this kind of a phenomenon? Seeing the extensor weakness, one may logically think lesion is more possible. But if it is, as Bindu said, lesion confined cutting the tendons, it can produce a local pathology. Not due to the nerve involvement. That's the point you have to put. So the examination is so, the lesson is that you have to very meticulously examine, find out whether what is the muscles affected, then think whether that lesion can explain that. We cannot explain by a lesion at that level due to the nerve involvement. Then we want to think what else, the tendon may be injured. That is the way it is. Okay, any questions?
Sir, how, sir, depression now, is he going to finish the rest of the 10 tendons?
Pardon?
How's the depression? Is she on medication?
That is beyond my this thing. My role job is only find out there is an organization and advice.
Sir, one doubt that this is how many months after the cut, sir?
This is 1 year, 2 years later. I'll show that history is.
Okay.
This happened 2 years back. And this deficit appeared recently. See, she had cut 2 years back. 2 months back, she noticed thickening of the skin. The neuroma is developing slowly. And 2 weeks, she noticed numbness of the left arm.
So then what is the cause of the tenosynovitis, sir? Late onset or?
Yeah, this is the thing because of the long-standing the distal intersection syndrome, because of the neuroma formation, thickening of the skin and fibrosis, the tendon got developed inflammatory reaction.
So, but we tend to get the contractures of the tendons, no? So, but there is a weakness in the extensors.
It's not a contracture. The muscle is not the one is affected. It is a tendon involvement. So muscle is intact. But tendon is not working, the apparent weakness is there. Muscle part is okay. Okay.
Is steroids help, sir? This patient?
Steroid. I don't know. I just go to the orthopedist. It is his problem, no? Tenosynovitis.
Yes, sir.
You must have given, I don't know. Okay, shall we close it? Any more questions? So a neurologist should also know something about the orthopedic problems as well. Okay, that is the final lesson.
Yes, sir. Majority of our patients are pain syndromes, osteoarthritis, low
Exactly.
backache, neck pain, and the periarthritis and all.
But the funny thing is that these things they don't read. They take the X-ray and say X-ray is normal. You go to some other place, and ultimately come to us.
Yeah, because most of the patients are seen by the orthopedician,
Yeah.
and they would like to have our opinion whether any nerves are affected or whether it's due some injury something.
Okay, then. Good night. Thank you.
Thank you, sir. Thank you very much, sir.
Thank you, sir.
ജോയിയുടെ ശബ്ദം കുറച്ചുകൂടെ കേൾക്കുന്നില്ല